Hi, everybody.
Hey,
Thank you for sticking with us today. I'm admitting everybody in. I hope that people got a lot of valuable information. I certainly did out of this conference. The speakers were just wonderful. And you'll forgive us for running over a little bit here. But we definitely want to have a chance to hear from you and to get your feedback, especially those of you who were able to do some digging and answer some of those questions that we have been sharing. So I am admitting people in from the waiting room. But I wanna go ahead. I don't know, Juan or Jaleesa, are you able to admit people in?
It's disabled, so they'll be able to come in. You're good to go.
Okay, so they're able to come in directly. Okay, great. So I'm gonna go ahead and share my screen. I want to share something that we're calling the principles of this disrupting danger and crisis response conference. And a lot of it is based on what you heard today. A lot of it is based on the Illinois law that we just talked about in the solutions panel. And it begins with the premise that individuals requiring mental and behavioral health or emergency services deserve a response that is equivalent to that provided to individuals requiring emergency physical health services. So again, if somebody's going into cardiac arrest, we don't say somebody get a police officer. We usually say send paramedics. And so we need that type of parity for mental and behavioral health services. If law enforcement would typically request EMS assistance when encountering an individual needing services in a physical health emergency, then law enforcement shall similarly dispatch mental or behavioral health professionals or call for medical transportation when encountering an individual in a mental or behavioral health emergency. All 911 call centers and providers of emergency services dispatched through 911 must coordinate with mobile mental and behavioral health services as established in that jurisdiction. Appropriate mobile response services shall be available regardless of whether that initial contact came through 911, 988, or another government phone number. And mobile crisis teams are to be culturally competent clinicians and peer support professionals with specific training on intellectual and developmental disability, including autism, because that is a population that is generally not thought of when designing systems. So these are what I'm calling the principles. I'm happy to share this later, but what I want to see us do is continue to work forward to make these principles into policy, particularly national policy. So I am going to stop sharing my screen now so that we can hear from you. And I think people are able to just raise their hands, or maybe I think you can actually unmute yourself at this point and tell us a little bit about what you learned as you did a little bit of digging around in your own communities. Does anybody want to start?
I can set the tone really quick, just going over like some of the responses now.
Yeah, or Juan can just tell us what he found through your responses. That might be easier.
No, I mean, there's definitely like progression. I feel like in the beginning, the initial question was like, what numbers do you call? And we saw like 800 numbers. We saw 911. We saw mental health crisis. So we saw like numerous different like varieties of responses. And I feel like if I were to ask the same question now at the end of the conference, the answers might be a little bit different now that we have a better understanding of how exactly 988 looks like. So I saw that first like response, but it's definitely just like, hey, we've come a long way since then. And we've learned about 988, how it's implemented. We've had robust conversations on like how it looks like in different localities. So it's been like a really good journey, especially going through like the next questions where we start seeing like do you know if your community has a mobile crisis response system? Like in the beginning, we answered 72% yes, 28% no. And I can imagine like this is a question like, hey, like how does it look like? Did my state receive money? How is it being implemented? Is it being implemented? How does it look like? And I think as Carlene mentioned, like the further and further we did ask these questions, like how is this determined? Who decides what's a response? Is it directly related to officers right away, or are there alternatives available? Who determines that? And I feel like the more we really like peel back the layers to this, we were starting to really ask ourselves, what do I exactly know about how it's implemented? Which are good questions to be answering, because it is just something that you want to think through before you decide to call like 988 or like 911, or how each one plays out. So it definitely is overall like looking at the general responses. We do have like those trends like coming up now where if we are asking ourselves, do they get dispatched with that police assistance? How does that look like? Yes or no, or I don't know. And I know I had to add I don't know to the last question, but it's an honest answer, because sometimes you just don't know. And that skepticism also leads to like hesitation where you're not sure how this is going to play out. And I think having those answers are really essential, and like being able to comfortably call 988, how exactly that looks like, how it's being implemented. So I'd be really interested to see like how anybody else is willing to talk about it. I'm going to hand it over to John to continue the conversation.
I assume that's me, Juan.
John
Thank you
got
very
y'all.
much.
That's you.
Yeah. Hey, I really like that last slide. I think that is answers just a ton of questions, Carlene. As I was listening to you, I thought, well, what if 911 was different from 988, and 988 was for both medical and mental health crises? So in other words, you just made a really great point about the parity between a medical illness and a mental health crisis. If 988 is the medical number and 911 is the public safety number, that would help clarify that and bring that parity into some sense of reality. I know that's aspirational, but I just wondered if you think there should be a different number for a public safety issue versus a personal medical / behavioral health crisis.
I mean, for me, I think that what we're talking about is how do we begin to unravel, 911, which should be for public safety issues, from, another service, perhaps 988, which can offer mental health services or health services. So I think we have to start, decoupling those thoughts that are or that background. I mean, it's ingrained because all we've ever had is 911, and start to think differently about what if we actually had parity for mental health and behavioral health scenarios. And once we start thinking along those paths, then we can start advocating. We start advocating locally. You start advocating at the state level, and certainly at the federal level, to say, we've got this thing wrong. We've got this thing backwards. How do we begin to build an actual civilian crisis response corps to keep people safe in these other scenarios?
Yeah. And I
that
just
aren't that aren't violent crime.
Yeah, and I just want to bring up Matthew's comment where he's talking about the intersectionality of like disabilities and how it just multiple dimensions to it, and how there's people with like physical sensory disabilities. And I think that's absolutely like the type of coalition building that should be addressed, where like if we're going to go and advocate for how this implementation looks like, it's important to recognize these intersectionalities and these like it just becomes like a coalition building angle. We don't want to make sure that all the parties are at the table, where it's not just specific type of disability. You want to make sure that we're just being inclusive in our advocacy. And you bring up a really good point about just making sure that we address it holistically.
Did anybody in the audience find out anything today as you engage with the questions that were part of the workshop? Did anybody find out anything new from their community? Don't be shy. Are there any other issues or questions that people would like to address here in this group setting?
We have Amelia's hand raised, and then
Okay.
I'll go to John afterwards.
Okay, Amelia.
Not so much something new, but something I had mentioned earlier in the day a couple of times, is we've had, where I live, we have quite an issue with crime overall. And there's been a lot of talk about the issue of police presence, and how they deal with stuff or not deal with stuff, and the talk of crisis intervention and the fact that we have an agency that they've outsourced to. I was talking to a fellow grassroots activist who let me know that they had spoken with some police officers who told them, you know, who they outsourced through, and that the agency holds all the power in this case. And the agency gets, like, the policeman can even, you know, if the policeman says, whoa, 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 we're not capable of handling this situation, let's call the crisis intervention people. They can call them, and the crisis intervention people can say, oh, well, no, that's not, you know, a high enough level of risk for us to come out and intervene. And they've basically told, at least what the police officer told this person, is that they will only intervene in cases where the person is threatening to take their own life or the lives of others. And I'm wondering, like, what do you do when the crisis intervention team is the issue? Because we're talking about needing crisis intervention teams, which we desperately do need. But in the case here, the crisis intervention is the issue because they won't come.
Yeah, no, I mean, what you bring up is a good point, and I alluded to it just a little bit in the last panel, the solutions panel, about how, you know, communities are expanding crisis response services in a lot of different ways, and I don't think that all of the models are great. I have had some experience in my own community with what I consider to be an older model, which is basically just adding county employees to go out and do crisis response work, rather than looking to people who are out in the community, you know, maybe nonprofits, or, you know, maybe peer support professionals who are not aligned, you know, with the county government, who want to go out and do this work, you know, independently. I think that, you know, when we sort of rely on systems that are sort of already embedded in our way of doing things, that they may have some resistance to maybe listening to the community and adopting some new mindsets or some new protocols that would help them to serve a wider group of people and sort of deter, you know, that old thinking around, you know, law enforcement response and hospitalization and that kind of thing. So I know that it's really, really important that we do find out, like, what our community offers for crisis response, and if it is a system that still doesn't really meet the needs, or a system where people don't fully trust it because of maybe some of the issues that you've raised, Amelia, then the community has to be at the table pushing and saying, we are not serving people people do not trust this system. We need to do something better. You know, that's when you've got to become an activist yourself and bring some others to the table, maybe a local ARC, you know, chapter, or, you know, a NAMI chapter to the table, and see what can be accomplished together to push that system to change. Thank you.
And I see John has his hand raised. Is that from last time or is that again?
No, that's again. Sorry about that.
No problem.
You know, I live in Corvallis, which is in Benton County, just north of Lane County, which has Eugene. And I grew up in Lane County. And I just want to let you know that, well, I would urge you to consider Cahoots to be a reasonable stepping stone, but it's not a good landing spot. And what I mean by that is that Cahoots grew out of the Whitebird Clinic, which is a substance use disorder clinic. They've been there for, I don't know, maybe 50 years in Eugene. And they were never designed to address accommodations or people with developmental and other disabilities. And in fact, they don't really train to that. If you look at their website and if you look at their news reports, which are basically public you know, they're basically press releases, they don't have any real discussion of disabilities. They may mention them, but I don't think they do that training, and I don't think they provide that service. They also only provide that service in the Eugene area. I don't even know if they go into Springfield, the sister city, but Lane County has a huge rural population. It goes from the coast to the Cascades, and they don't provide services to rural Lane County. And so they get a lot of really great press, and they have been really good at changing the conversation. But I just don't think that that's the kind of landing site that you portrayed in your last slide there, Carlene. And so with all due respect, I just wanted to mention that.
No, I think that's a good point, John. You're absolutely right. I mean, IDD, I mean, developmental disabilities are not generally part of this conversation. When we're talking about crisis response, we usually focus solely on the mental health aspect, the mental health crises aspect. And so you're right, we've got to go further, and we've got to talk about how do you respond to people who may have multiple disabilities. I mean, somebody may be deaf and they may be bipolar, you know, et cetera. And so that's why it's important to make sure that we have people with disabilities, cross disabilities at the table and part of this conversation. And a lot of the crisis response models that are already in existence don't actually have peer supports either. And sometimes when they do bring on peer supports, it's not necessarily going to be somebody who maybe has autism. So you are right. We need to go further, even with the existing crisis response models that we already have, and Cahoots is, you know, certainly lifted up as the gold standard. And with that, did we have anything else from our participants today?
Yeah, not so much a question, but I know there's some general dialogue in the chat around just building like local advocacy efforts and being inclusive of like disability organizations, as well as just like the difficulties and just trying to like get that started. I know you do a lot of local work in Montgomery County. Do you want to like talk at all about like how like building up coalitions generally looks like, or your experience and any advice you would give to those looking to do something along those lines in their own area?
Yes, I mean, I can tell you that it's hard work because I mean, you're coming up against, as I said, embedded systems. So not only with the police department, but the way that our crisis response services work is they're deeply embedded with the police department. I mean, they're county, you know, our crisis response workers are county officials, they're county social workers, and not everybody is on board with this whole idea of social workers going out into the community and providing crisis response. We certainly get pushback from folks who've been with the county maybe 20, 30 years. And who prefer to have a co-response, which is, you know, police are always present. when a crisis team, a mobile crisis team goes out on one of these calls. That's what they're comfortable with. And as one of our panelists, Sam Fletcher, was saying, in the solutions panel, the issue with that is that in a lot of co-response models, it's not as if you get one police officer and maybe one, social worker or peer support worker. No, you get 10, 12, 14 police officers and a social worker. That's what you get. So what you get is an overwhelming law enforcement response. If you're a person in crisis, what do you see? You see these people with guns and badges, and sometimes they have the gun, they've got their hands either on the holster or they've already got the gun out. So as an activist on the local level, it's frustrating because while we have gotten some successes, meaning we got additional funding for mobile crisis units, as I said, the issue now is that it's not like a fresh start. We just funded more county positions, and unfortunately, we've got a lot of old mindsets about doing this type of work. So I see one hand from the ARC in CCJD. So,
Hey,
that
Carlene, it's
Leanne?
Leanne.
Hi,
Yes.
Leanne.
Hi, I just wanted to add to the point and it was
You cut out, Leanne.
wonderful. This mission is so needed. Unfortunately, bringing up disability issues within the criminal justice, criminal legal system is often overlooked in many communities. So to have this opportunity is amazing. So thank you to everyone who made this possible and to the wonderful presenters today. But I wanted to pick up on the point that you just said about having too many police respond. That we're seeing that too with regards to training. So when we're providing training, and I'm sure that is why there's such a big concern about training even working, because we see too much of a the lens is coming from a policing perspective rather than the community perspective. And so what we're looking to do through the National Center on Criminal Justice and Disability here at the ARC is really bring more of a community perspective to all of that, and having people with disabilities who are the trainers. It's not just looking at providing peer support specialists in co-response, people with IDD who can do that, but how are they involved from the beginning in the policy, talking about all of these issues in their community, showing law enforcement that they can use their expertise in these situations. That is powerful. And we don't see that happening in current crisis intervention team training or CIT training. We don't see that in traditional law enforcement training. So I think that can be one of the small steps in a very large, ongoing strategy to really change attitudes and understanding. But I also agree too with the panelists earlier, talking about the training in and of itself will never work. There has to be a much more comprehensive approach. And so there's just great ideas. And I know that you're going to tell us about next steps and how we can all continue this conversation together, because it definitely can't stop here.
No, thank you so much. And thank you all for attending. And thank you to all of our wonderful speakers who were able to be here today. No, as I put up the principles of the purpose of this conference, we're going to continue to work towards those principles here at the ARC on the federal level. And I ask you to also work towards those principles on the local level and the state level, and to continue to join us as we lift up this conversation. And I hope that you will also do the same and begin to lift up this conversation in your local communities, maybe through media resources, maybe by joining up with some like-minded groups, as Candace Coleman reminded us of at Access Living, how powerful that is. To continue this work. And we have, the registration list. So we will also be in touch with you all on some next steps and follow up as well. And the lobby, I think, will be open for those of you who registered through the Zoom's conference event for at least another couple of weeks. So you're welcome to come back in and view sessions. And there were some materials that you can also print, some PDFs. And we will also save these sessions, and probably, I think we're going to make them available on the ARC's website as well. So the lobby will be open until November, so you can come back in and get these resources. But you're also welcome to be in touch with me. I will put my information, Carlene Ponder, in my email in the chat, ponder@thearc.org. I also want to thank our wonderful interpreters and captioners who have been working with us very hard throughout the day. Thank you very much. And with that, we are concluded for this session. Certainly not the end, but it is the beginning, we think, of a national conversation from the disability perspective. So thank you again for joining us.